Christian, what time?
We will start in 1 minute.
Okay.
Mm. Okay, welcome everyone to today's Karolinska Suicide Seminar. My name is Christian Ryck. I'm a professor of psychiatry here at Karolinska Institutet in Stockholm, Sweden. And this is a lecture in our Karolinska Suicide Seminar series. And very welcome all of you who listen. This lecture will be recorded. You as participants will not be seen or heard, and you can write your questions in the Q&A function at the bottom of the Zoom window. Today we are very honored to have Dr. David Tolin here with us. David Tolin is the founder and director of the Anxiety Disorder Centers at the Institute of Living and an adjunct professor of psychiatry at Yale University School of Medicine. He's the author of over 250 scientific articles and several books. He is also the past president of the ABCT, Association for Behavior and Cognitive Therapies, and the past president of the Clinical Psychology Division of the American Psychological Association. And recently, Dr. Tolin and others published a very interesting article that caught many's attention, I think, here, about brief cognitive behavioral therapy for suicidal inpatients. And I think I speak for many of us here when I say that this is something that is very dearly needed, as we know that the risk for suicide is extremely high after discharge from hospital. And it seems to make sense then that we do something before discharge and not wait with treatment until after discharge. So I'm very much looking forward to hear your talk, David. Please fire away.
Thank you very much, Christian, and hello, everybody. It's nice to be with you today. So we're going to be, and as Christian mentioned, we recently completed a study of inpatient suicide prevention, and that's going to be the bulk of what I talk about today. Let's see, there we go. I do want to thank a couple of really important key collaborators, David Rudd, who was a very important consultant on our research, and Gretchen Diefenbach, who was my project manager on the inpatient suicide trial, really is and was the lead author on the JAMA Psychiatry paper, and in fact, drafted most of the slides that you're going to see today. This is a book that I highly recommend, which doesn't talk about inpatient treatment. We're working on that, but does kind of give an overview of the kind of work that we're going to be talking about today. So David Rudd has done a lot of work in the area of suicide prevention. And one of the things that he has identified in a systematic review is that if you look at all of the things that have ever been proven effective for reducing suicide risk, it really boils down to a small number of essential ingredients. Those treatments that are effective appear to be based on a simple empirically supported model with high treatment fidelity by the clinician, significant adherence to the treatment protocol by the patient, with an emphasis on skills training, self-management, and access to crisis services. And so we wanted to make sure that all of these were part of the treatment that we put together. Our treatment is based in part on the fluid vulnerability theory of suicide. And the basic idea behind fluid vulnerability theory is that suicide risk is comprised of both stable and dynamic properties. And so there are some things that elevate a risk over time, but the suicidal episodes themselves tend to be time limited. And the baseline risk varies based on vulnerabilities and determines the threshold for activation. And then the acute risk occurs when a certain combination of vulnerabilities and stressor exposures occur. So the idea here is that individuals with high baseline risk experience suicidal episodes more often and for longer periods of time, whereas individuals with low baseline risk experience suicidal episodes less often and for shorter periods of time. When we see people with multiple suicide attempts and lots of non-suicidal self-injury, those are the clearest markers of an elevated baseline risk. The acute suicide risk has a tendency to resolve when the factors that maintain the suicidal mode are deactivated or reduced. I'm going to come back to that discussion of suicidal mode in a moment. And after the resolution of an acute suicidal episode, the individual returns to his or her baseline risk level. This is an example of what I'm talking about. These are two hypothetical patients measured over time and with regard to the degree of suicide risk rated from 0 to 10. And what you can see is that the patient in red has a relatively low baseline risk, and then there's an acute suicidal crisis that occurs somewhere in the middle here. By comparison, the patient in blue has a much higher baseline suicide risk. And so when they go into an acute suicidal episode, you'll notice that it's higher and it's a little bit more prolonged. This is the suicide mode that I was speaking of. This is essentially a schema. It's a case conceptualization, which suggests that there is an interaction of emotions, thoughts, behaviors, and psychophysiological signs that are malleable and that guide our implementation of treatment. This is an example of a sample diagram of a suicide mode. And what we can see is down at the bottom of the screen, there are these baseline predispositions that could be cognitive, they could be emotional, they could be behavioral, they could be physical. And when those predispositions, moving up in the graph here, when those predispositions are met with external triggers like interpersonal conflict, being criticized, financial troubles, and so on, we go into the suicide mode in which these cognitive, behavioral, emotional, and physical signs become activated. This leads us to brief cognitive behavioral therapy, or BCBT. Now, I'm going to show you here the outpatient version. So this is David Rudd's treatment manual, in which it takes place over 12 sessions. And what you can see is that there's a lot of stuff packed into each of these sessions. At the first phase is emotion regulation, and that's the first 5 sessions that include things like a risk assessment, crisis response plan, means safety counseling, working on a treatment plan, sleep disturbance, relaxation, reasons for living, a survival kit. They then move on to a second phase, which is cognitive flexibility, which is much more of a cognitive strategy, a cognitive therapy strategy. And finally, moving on to phase 3, which is relapse prevention. And that's done over 2 sessions. Now, I'll just talk about that briefly here. David Rudd showed us this, that when you do outpatient BCBT, it's associated with a 60% reduction in suicide attempts for individuals who have attempted suicide. What we needed to do was adapt this BCBT for an inpatient setting. Now, there's a couple of reasons that we need to do this. One is that there is very little research on inpatient suicide prevention treatment, which is surprising, since inpatient treatment is probably the #1 thing we use to prevent suicide, and we know almost nothing about its efficacy. What we do know, as Christian alluded to at the beginning, is that there's a very high suicide risk post-discharge. In fact, in the immediate aftermath of a psychiatric hospitalization, the risk of suicide is 100 times greater than the population average. It's a common reason for admission. And we know that specific suicide interventions tend to be more effective. And so what we're going to do is leverage the inpatient environment, which includes the access to providers, the availability of treatment, and the readiness of the patient for therapy. What we created was a 4-session protocol, trying to distill David Rudd's 12-session protocol down to its very essential elements. And I'll talk about each of these as we go, but briefly, session 1 is a narrative review and case conceptualization and a crisis response plan. Session 2 involves reasons for living and what we sometimes call a survival kit or a hope box. Session 3, we develop coping cards and we do means restriction counseling. And then finally, in session 4, we do a review of all skills and some relapse prevention. So I'd see that's a total of 4.5 hours of therapy. In our randomized control design, we randomly assigned patients to either treatment as usual, which is treatment as usual here in the hospital, or treatment as usual plus what we're going to call now BCBT-I, or brief CBT for inpatients. We then assessed everybody and we followed everybody monthly after discharge for 6 months. And the reason that we picked 6 months is that is the period of highest suicide risk. Essentially, we had 200 people in the trial, all of whom had a prior suicide attempt and were in the hospital. And I'll let you look at the rest of the demographics here. But I want to just point out it was a fairly representative sample. Oh, the one thing I will mention down at the very bottom here, and because I'm going to come back to it, is that 60% of our sample was diagnosed with a co-occurring substance use disorder. And I'm going to talk about the importance of the substance use disorder as we go. The outcomes were suicide attempts. That was the primary outcome, using the Columbia Suicide Severity Rating Scale as well as a review of medical records. We also looked at suicidal ideation on the Adult Suicidal Ideation Questionnaire, as well as the presence and number of psychiatric readmissions. So let's look at the results here in terms of suicide attempts. Statistically, there was no main effect of time and no interaction with substance use disorder. There was a main effect of treatment condition insofar as the odds of a suicide attempt in the BCBT-I group were 60% lower than in treatment as usual, exactly the same efficacy that David Rudd got in his outpatient trial. We did get a main effect of substance use disorder such that the odds of suicide attempt overall were more than double when a patient had a co-occurring substance use disorder. When we look at suicidal ideation, it's not nearly as impressive a picture. There was a main effect of time, insofar as everything got sort of better, but there was no significant condition by time interaction, and post hoc analyses showed only at the 1 and 2 month follow-ups was BCBT-I superior to treatment as usual. What that means then, if you take these last two slides together, is that this treatment is quite effective at reducing suicidal behavior. It doesn't seem to do much for suicidal ideation. So we think of this as a very behavioral treatment. We also saw an effect on psychiatric readmissions. Here we did get an effect of treatment condition and substance use disorder. So when the patient didn't have a substance use disorder, their readmission rate over these next 6 months was 71% lower than in treatment as usual. On the other hand, when the patient did have a substance use disorder, there was no difference in the readmission rate. So there's something there about substance use disorders that is making patients not necessarily suicidal, because the suicide rate was still down, but they are still being hospitalized at an elevated rate. So let's talk about these sessions of BCBT-I. In all of them, we set an agenda and we do a mood check. Scale of 0 to 10, how's your mood today? We do a review of the lessons learned and the patient's crisis response plan, and we talk about skills practice since the previous session. Then we introduce a new skill and practice it in the session. We then assign skill practice, and we ask the patients to rate the likelihood that they're going to actually try these things, that they're actually going to use these strategies that we are teaching them. And we ask them for a new lesson learned. The lesson learned is essentially asking the patient to synthesize what they have learned from the session. So when we set an agenda, we usually do this on a whiteboard in the room, and the clinician is drawing things out and providing structure and getting agreement from the patient. So an example might be the therapist says, first we'll do our mood check. Next, we're going to review lessons learned and review your crisis response plan and make some revisions because, like I said, it's a working document. We'll review the practice, which was to read the reasons for living list every 2 hours. We're going to talk about means restriction counseling. We're going to create some coping cards after that, and then we'll figure out how you're going to practice, and then we'll talk about the lessons learned for today, okay? This is the mood check, in which we are measuring not only mood, but we're also measuring the degree of wish to live and wish to die. And I don't have a slide for this, but very recently we did some analyses suggesting that the ratio of wish to live and wish to die is a very powerful predictor of subsequent suicide attempts. In fact, it performed better than all of the psychometrics that we had. So in sessions 2 through 4, we talk about the lesson learned from the previous session, and then we do the crisis response plan. And the idea behind the crisis response plan is we want to increase accessibility to things that will help. So we ask the patient to talk through each step of their crisis response plan, and we ask them to keep doing it even though it's repetitive. Then we do a lot of between session practice where we're praising the patient's efforts, problem solving as needed, and incorporating any new insights that the patient brings into their treatment. As we introduce a new skill, we provide a rationale for that skill, and we fit it into the patient's individualized case conceptualization. We then practice that new skill, reinforce the efforts, and reinforce any changes in mood that are noted during the session. When we assign between sessions skills practice, homework, we provide a rationale, and we encourage the patient to practice these things even when they're not in crisis. Now, we tend to not use the term homework because, at least in our population, the term homework has a very academic connotation that puts off a lot of patients. So we just call it skill practice. So an example might be, so for practice, I want you to make 2 more coping cards, and let's make a schedule for you to look through your coping cards. How about at every meal? Do you want to say before the meal or after the meal? Patient says, I'm going to do it after the meal. Okay, so after every meal, I want you to review these coping cards. Look at them as though they're flashcards. Read the front and then the back. And we'll talk more about the coping cards as we go today. And as I mentioned, we're asking patients for each skill that we introduce to rate the likelihood that they will use it. So how likely between 0 and 10 are you to use your coping cards? And the patient may say, probably like a 6. I'm more likely to use the survival kit. And then the therapist is going to ask, what makes you less likely to use this? And the patient says, because it's so many cards. Okay. So we can think of a solution to that, a little problem solving. What if we took a rubber band, put all the cards together, and then you put them in that same place that we would keep the survival kit? Maybe that would make it more likely for you to use it. And the patient says, yeah, it's just so many cards, I'm just worried I'm going to lose them. Maybe if we stapled them or used a binder clip. Therapist says, that sounds possible. Would that change the number? Patient says, yeah, then it's more like an 8. And then we end each session with the lessons learned. What, in the patient's perspective, are the key take-home points of the sessions? We identify these collaboratively. We ask the patient, and then if the patient's having difficulty, we prompt them. And we try to deepen the lesson learned to enhance the therapeutic value. And we ask the patient to write that lesson down in their treatment log in their own words. Session 1 involves a narrative assessment. a conceptualization of the suicide mode, and a crisis response plan. The narrative assessment is inviting the patient to tell the story of the suicidal episode, usually that brought them into the hospital. And we might use some guiding questions. So we might ask the patient to describe the sequence of events, like what happened then what happened, at what point did you decide to make a suicide attempt? And we identify the modes of the suicide, or the components of the suicide mode. For example, what specifically was going through your mind at that moment? What was the emotion you felt at that moment? Where did you feel that sensation in your body? We formulate the model as we go and provide emotional validation, like, thank you for being willing to share your story with me. I know it's not always easy to remember the details, let alone share the details. I'm going to show you a video here, a brief one, that just shows a little bit about asking the patient for a narrative assessment.
So the next thing that I want to talk about is what brought you in here. I know you had an attempt, and that's the thing that I'd like to discuss. I'm hoping you can share with me your story of what happened.
Yeah, so the thing is that this actually wasn't my first attempt.
Okay.
I've had a couple of others.
Okay.
And I'm noticing this pattern where every time an attempt happens, it's after I've been in a unhealthy relationship or a friendship that goes badly. And then I just really immerse myself in work and become this workaholic and start putting so much pressure on myself.
It's good that you're noticing a pattern there, because that pattern is going to help us fit all this into a model that we can use during our treatment.
Okay. So this time, I was friends with this guy, and he was really interested in being in a relationship. And I wasn't that interested, but we stayed friends. And he kept promising me all this stuff. Like, he kept saying he'd help me pay for my car. That didn't happen. And then he said he'd help me pay my rent, and that didn't happen. And so I kept getting into this hole that I had to dig myself out of, and I started looking bad because of other people's failures, and I started worrying that I would be a failure.
Looking bad and being a failure.
Yeah.
What was the concern there?
Then my value would go down.
Oh, I see. So it gives you value when you don't have to rely on somebody else for those kinds of things.
Yeah, I take a lot of pride in working and doing well and being in school, and that makes me feel good.
And without those things?
My value goes down.
Okay. So what happened next in this relationship?
So then he started calling me, and he was like, my brother's saying all this bad stuff about you, and he just kept calling me and saying he's slandering you, and then I would get upset, and he would be like, oh, but I'm not listening to my brother. And I was like, then why are you telling me all this stuff that he's saying about me?
I see. So kind of tainting your image.
Exactly.
Is that related to the value?
Yeah, definitely. It ruins my image. It makes me look worse.
Okay. Now, you've been working on overcoming some other personal problems in the past. Is that right?
Yeah. I know. It's been really hard for me to battle these demons over the past couple of years. And I was in a domestic violence relationship, and then I became an alcoholic and made some really bad decisions.
When did that period end?
About 2 years ago.
Okay. Were there other stressors too?
Recently, yeah. So I went to my friend's bridal shower, and there was this other guy there who was interested in me, and he asked for my phone number, and my best friend gave it to him. But then I was talking to him, and I said that I'm not interested in him, and my friend kind of gave me a heads up that he's not boyfriend material. And so then he told her that, and now she's upset at me too.
She's upset at you, so there's anger at you.
Yeah.
Okay. Just sort of an upset feeling toward you.
Upset feeling, bad energy, yeah, she's just...
Okay. Now, I seem to recall there was also something going on with your mom too.
Right.
What was that?
Yeah, so my mom said, so I just called her and I said, I think I'm going to rent an apartment. And she was like, oh, right now I think that you should look at getting a house. And I don't think she even meant anything by it. But she was like, at your age, I had a house. And so then I just got upset about that.
It's almost like you're being accused of not working hard enough, not having enough, that sort of thing.
Exactly, by all these different people, not being a good enough friend, not be the person that I want to be.
How did that feel emotion-wise? Like, can you give me a couple, like, feeling words?
Hurt,
Hurt?
painful,
Okay.
demeaning.
What period of time did this all take place in?
The slandering from that guy's brother was like took place in about a week, but everything else seemed to happen in like a day.
Okay. That's a lot in one day.
Yeah.
All in the same day.
Yeah.
And so what happened next?
So then I went to my friend's house and we were just going to hang out, and she went to the bathroom and I just got really upset. And I got up and I was going to go take a drive. And she came out and she was like, "Where are you going? You tell me everything."
Mm-hmm.
And I just said, "I just want to go for a drive in my car."
Okay.
And so I went and I started playing this song, Naked by LMA.
Uh-huh.
And
I don't know. What's it about?
it's about this woman that she just wants people to appreciate her for her and not for all these like materialistic things.
And you feel this way about yourself.
Yeah.
Okay.
And so I just really felt that way as I was playing the song over and over again
Yeah.
and driving around, and I just wanted to be appreciated for me.
Mm-hmm.
And I just started crying, and I pulled over in the park, and I'm on antidepressants, and so I just started taking them because I didn't want to feel this way anymore.
Did you take the antidepressants with the intent to block your emotions, or were you trying to kill yourself?
Both.
Yeah.
And I started taking, I had some medicine for headaches, and I started taking that too. And
Yeah.
I just wanted to feel better. And then I started crying harder and panicking and got really overwhelmed.
What happened next?
Well, I remembered that I was told that when the clinic is closed, I should call 211 if I ever feel that way.
Is that what you did? Okay. Anything else after that?
I remember police coming in an ambulance.
Okay. Wow. It sounds like you were in a really tough place, and I appreciate you sharing this with me. This helps me a little bit to understand what was going on with you, and will help me to put some things together for our treatment. But I know that's not easy to talk about.
So it's a very frank discussion of exactly what led up to the suicidal incident and what the suicidal incident was comprised of. We then introduce the concept of the suicide mode, which is a simple model that helps us understand both the baseline and acute suicide risk. It is a validating experience for most patients to diagram their suicide mode, because for them, the suicidal crisis is really confusing, and we're bringing some clarity to it. The key points that we want to emphasize as we're introducing the suicidal mode to the patient is that your vulnerabilities are just that. They are vulnerabilities. They are not destiny. That the suicidal crises tend to be time limited. So the idea is that what we are trying to get the patient to do is just buy time. When you're in a suicidal crisis, can we just pass the time in a safe way? The suicide mode components are each addressed with skills that they're going to learn in BCBT-I. And that the last piece is that the patient's choices all the way through the process either lead them closer to a suicide attempt or lead them farther away from a suicide attempt. And we're just going to encourage them to keep making choices that lead them farther and farther away from a suicide attempt. So we develop this model collaboratively. We do it on the whiteboard. And it's a very directive process with lots of input from the patient, where we're really trying to hash this out and get agreement. We assess this for patterns with past attempts. You know, many patients have multiple suicide attempts, as did the young lady you just saw in the video. And so we might use this to talk about past attempts as well. We try not to get too bogged down about the exact correct placement. I don't know, is this an emotion or is it a physiology? It doesn't matter, right? What we're really trying to do is help provide some clarity and give the patient a conceptual model that they can use. We then have the patient write that down in their treatment log, as you see here, and we ask them to take a picture of it on their phone so they've got it always. These are some common predispositions. This is the vulnerabilities. Right? Cognitively, it may involve a patient's self-regard and the degree of cognitive flexibility and problem-solving capacity. Emotionally, the presence of a psychiatric disorder or emotional lability or activation of the HPA axis. Physically, one's genetics, one's medical conditions, one's demographics all play a role. And behaviorally, prior attempts are a vulnerability factor. So is your capacity for emotion regulation. So are your interpersonal skills, etc. We then, having talked about the vulnerabilities, talk about the trigger. So what actually brought those underlying vulnerabilities into an acute suicidal crisis? And the clinician might say here, the next part of the suicidal mode is what we'll call triggers. Triggers are stressful situations or problems that you experience in life that activate a suicidal crisis. Triggers can usually be categorized into one of two groups, external and internal. External triggers are stressful situations that happen in your life, such as a relationship problem, financial hardship, legal or disciplinary problems. Internal triggers, by contrast, are mental or physical experiences that occur inside of you, like depression, or worrying about a problem in life, or thinking about bad things that might happen to you. In many cases, suicidal crises are triggered by life events, but other times they're triggered by some sort of feeling or experience inside of you that's not necessarily tied to any life event. Based on the story you just told me, it sounds like your triggers included X, Y, and Z. And then we move up to the suicide mode. This is the point where the schema has essentially become activated. And we talk about the cognitive, emotional, physical, and behavioral components of the suicide mode, including behaviorally the preparations that the patient made for the suicide attempt. The next piece is to develop a crisis response plan. And the rationale here is that we give to the patient is that when you're in the suicide mode, your problem-solving capacity has become impaired. So what you really need is a very accessible, concrete plan. So we help the patient to identify what their warning signs are. That is, how do you know the suicide mode is becoming activated? What are some self-management strategies that the patient can do? Who are some supportive other people, like friends or family, that they can contact? And then finally, as a last resort, who are the professional resources that you can contact? Can we contact your providers, or can we get you to emergency services? As we introduce the crisis response plan, I think I pretty much said this, but we use an index card to write down the crisis response plan, and we ask the individuals to handwrite it to make it a little bit more personalized. So as we talk about the warning signs, we might ask the patient, what are some of the things you notice inside of yourself during these situations? Or what are some of your indicators that things aren't going so well and are getting out of control? Or if we wanted to prevent this from happening in the future, how might we know when you're heading down this road? We want to make sure that we're ensuring that the warning signs occur far enough in advance to be helpful. That is, I'm swallowing pills is not a very good warning sign, right? We need to think about what's coming before it in time. And if the patient has difficulty, we provide them with a list. So it's again, a very directive kind of therapy. So these are some examples of common warning signs. They may be certain thoughts. They may be mental images. They may be certain emotions or feelings. They may be certain behaviors or actions, or they may be physical sensations. And we'll often suggest these to the patient. Was this a part of what's happening? Did you notice this? We then give some ideas about self-management. When you're feeling upset or stressed, what are some things that help you to calm down or feel less stressed? And even if the patient says nothing, we might ask them, what are some things you used to find helpful when stressed, even if you don't do them anymore? So we ask about things that have worked in the past. Now, sometimes what you find is that the patient's strategy is very limited and it only would work in one setting. So we prompt them and we push a little bit to ask about other strategies that might work in other settings. And again, if the patient has difficulty, we provide a list that looks kind of like this. What are some things that people sometimes do when they're in crisis? Could you maybe incorporate one or more of these into your repertoire? We pay attention to social support. When you're feeling stressed or upset, who helps you to take your mind off of things or cheer you up? Or who do you know who provides you with support during tough times? People often have a family member or a friend or a coworker who supports them in their times of need. Who would that person be in your life? Now, if the patient can't identify any social supports, we provide some general suggestions. And if they still can't, we just move on. That is, some patients are truly socially isolated, and we don't want to belabor that fact. We also point out that reaching out to somebody in crisis doesn't necessarily mean that you have to talk about the crisis. If you want to call your friend or your coworker when you're in crisis, you don't have to tell them that you're feeling suicidal. We could talk about other ways that you could structure that conversation. And then finally, there's the emergency support services, which in my country is 988 or 911, or going to the hospital. And we ask the patient, would you go to the emergency service? And if the patient's reluctant, we ask them for their reasons why. And we ask, would you include emergency services on your list, even if you don't right now feel very motivated to use them? So I'll show you another video here of working out a crisis response plan with a patient.
Well, the reason that it's so important for us to have an understanding of this model is because the behavioral responses that you're currently using aren't working, right? So we want to provide you with skills that you can use when you start to get into the situation so that you won't go to the point of a suicide attempt, right? Mm-hmm. That's what leads us to a crisis response plan. Have you ever made a plan for something?
Yeah, I'm like obsessive about planning.
Okay, what about like a crisis plan, like there's a big storm outside coming?
Yeah, I have a storm kit and flashlights and everything's color-coded.
Perfect, so this is similar. This is a plan that we create for an emotional storm, right? Which would be a crisis. So the first step, when would you say is an appropriate time to use this plan? What are some signals?
When I feel a lot of criticism around me.
A lot of criticism.
Mm-hmm.
So let's write that down, definitely. Criticism, conflict,
yeah.
Right? Okay. That sounds like a big one. So criticism, interpersonal conflict with friends. Let's put depression and anger on the list because that's an internal experience that you had during that time, maybe depression / anger. Mm-hmm. Not feeling valued, yeah?
Yeah.
Okay. The second step, once you recognize that you're in that state, how do we thwart that? So the second step would be to think of things that you could do for half an hour that would bring you from like a 10 to a 7, right? So what would you say are some things that you could do? Because the behaviors that you're currently doing are not working, as we mentioned, right? They made you feel worse. So what are some behaviors that would make you feel better?
I used to dance a lot when I was a kid.
So in a crisis situation, right, where you'd be going for a drive or listening to sad music repeatedly, do you think dancing for a half hour would help?
Maybe, yeah.
Do you want to put that down? Would that be something you think you'd actually do?
Yeah, I think I would do it. My best friend likes to play music in her kitchen sometimes, and we like to dance and be kind of silly.
Okay. And what if you were alone?
Maybe.
All right, so that's a maybe. It depends on where you're at, but that's one thing that you could potentially do. Mm-hmm. What could be something you could do anywhere?
Work out.
Exercise. Let's put that down.
In the past, I've done yoga. Journaling has helped me before.
Mm. You know, that can be tricky because, you know, it depends on, we were talking about how sometimes you can be in a negative place, you know.
And then you're journaling negative thoughts.
Yeah, right.
And then that perpetuates more negative thoughts.
Exactly. You got it. So we want to make sure that we're choosing things that are really going to lead you in a positive direction, right? So let's think of one more.
I don't know. It has to be something physical because that always makes me feel better.
Okay. What about eating something really yummy?
Like cooking?
Yeah, you like cooking.
I do.
Okay.
Yeah.
So what about cooking? If cooking helps you feel better, I'd say that's a great one to put on the list.
Okay.
Do you do self-harm behaviors like cutting yourself?
No, I did when I was 16, between the ages of 16 and 18, but not since.
Okay, I just want to be cognizant that what we're choosing isn't eliciting that.
No, I haven't done that since I was
Okay.
18.
We're looking for things that will calm you, right?
Mhm.
So you mentioned exercise, you mentioned yoga, you mentioned cooking for a half hour, you mentioned dancing. Fabulous. So that all sounds really good. So step number 3 would be, if those don't work, it's reaching out for support of somebody that you're close to. And it sounds like during the last time that was a behavior that you struggled with. So who could you think of who would be a good support for you to reach out to if you were to find yourself in a crisis situation?
I could reach out to my boyfriend
Mhm.
because he also struggles with some stuff.
So your boyfriend is your current boyfriend.
Mm-hmm.
Who's that?
Terrence,
Okay,
and I've been friends with him since I was 12 years old.
I see. You're romantically involved now.
Mm-hmm.
Okay. Is there somebody else who might be? We also know that interpersonal relationships and intimate relationships can at times be a trigger
Mm-hmm.
for you. So is there somebody else long-standing who you've known for a really long time, like a friend or something like that?
No, a lot of my friends don't really speak to me anymore.
A family member?
I'm not really close to family.
Huh. Is there a teacher or somebody outside of friends or family?
No, I don't really let people in like that because last time, whenever I used to, it would blow up.
So Terrence really seems to be the one who's close to you at this point.
Yeah, and my female best friend Monica.
Okay, that's good. So you have these people to reach out to.
Mm-hmm.
Now, you don't necessarily have to tell them that you're having a crisis. You can just have a pleasant conversation, and that's an alternative activity. You know, you can open up to them if you'd like, but you don't have to.
Okay.
So then the last step is, let's say that doesn't work, or they're not available. The last step is to contact professionals.
Mm-hmm. Yeah, I have a therapist and a psychiatrist.
So you can reach out to both of them. So let's write their names down there.
Okay.
And we'll get their numbers, and we'll write them on the plan as well. And obviously 911,
Mm-hmm.
if you can't reach those people, so let's put that down too.
Okay.
There's also a national suicide hotline. It's 1-800-273-TALK. So let's get that down too, 1-800-273-TALK. Or you can go to the emergency room, right?
Mm-hmm.
And it sounds like you did that. You called 211.
Yeah, that was my first time doing that.
Okay. So how likely, on our scale from 0 to 10, with 0 being not at all and 10 being definitely, are you to use this crisis response plan?
Probably like a 7.
Okay, it's a 7. If there are some things that you can think of that'll help bring that 7 up to an 8, 9, 10, let's think about those and talk about it tomorrow, okay?
The really tricky thing, and I don't know if you saw me doing it here, is making sure that the crisis response plan doesn't include iatrogenic things. I mean, so when she said I wanted to cook, the first thing that came through my mind is she going to cut herself with a knife? So I had to inquire about that. And when she said I want to include my boyfriend on the list, I had to ask, is that really going to be a source of support, or is that going to stress you out even further? So the high quality response plan, crisis response plan, is agreeable to the patient, it's feasible, it's flexible, it's accessible on a note card or on the patient's phone. It does not include any additional triggers. It's personalized, and it's detailed enough to be actionable. These are some examples of writing down on a card what the crisis response plan is, and we might have the patient then take a picture of this and put it on their phone. We also do some introduction of deep breathing as a sort of generic self-management skill. The rationale here is that it slows down the sympathetic nervous system. It's easy to do. Most people say they've tried it. Most people say, oh, sure, I've tried breathing. And we ask about, what was it like? How did it work? Now, sometimes they say, it doesn't work for me. And I'll ask them, show me what you did. Because often what we find is that what the patient's really doing is sort of hyperventilating and chest breathing. And we're going to encourage diaphragmatic breathing, putting a hand on the stomach and letting it go and being very slow, very even, sometimes counting the breaths as they go in through the nose and out through the mouth, etc. The safety plan here, it has overlapping content with the crisis response plan. but we fill this out with the session. And we, in our inpatient trial, shared that with the unit clinician. So you see here what we're asking the patient to do is write down what their warning signs are, what their internal coping strategies are, who the people are that can help and the social settings that can help, the people that they could ask for help, and the professionals that they can go to, as well as making the environment safe, which we're going to talk a little bit about means restriction counseling in a second. Session 2 is the reasons for living list, as well as the hope box or survival kit. The rationale is cognitive bias, that when the suicide mode is activated, the person becomes very focused on reasons for dying, and they fail to remember their reasons for living. So we want to help share that concept of cognitive bias with the patient, and then use that to launch a discussion about what are the reasons for living. And we increase the emotional salience of those reasons for living by asking questions like, tell me more about that, or why is that person so important to you? We might do a visualization exercise in which they imagine some of their reasons for living. And then practice always. Keep a written list of your reasons for living. We put it in the treatment log, put a picture on your phone, and review that list routinely. And again, not just in times of crisis. We want them doing it as a regular activity. So we ask the patient, what are your reasons for living? What gives you a sense of purpose and meaning in your life? What stands in the way of you killing yourself? Now, if the patient says there are no reasons for living, we might just ask again, what gets in the way of suicide? And we don't necessarily quibble over the terminology. We can also use information from the narrative assessment to help identify at least some reasons for living. So these are some examples: faith, kids, dogs, want to make my mother proud, make music. Even things like, I love waking up in the morning and seeing snow in the mountains, or a patient said, as dumb as it may seem, there's a book I want to read that comes out in January. Okay, whatever it is, let's put it on the list. We do the visualization exercise in which we savor a positive memory connected to one of the reasons for living, letting the patient tell their story using Socratic questioning, integrating all 5 senses if we can. And what we're really trying to do is increase the accessibility of these positive memories. And as we do it, we bring the patient's attention to changes in their mood. It could be mood ratings, or it could be a behavioral observation, like you smiled just then as you were thinking about that. I'm going to skip the video here in the interest of time. But then we create a survival kit, or sometimes called a hope box. It is literally a white box. We bought a whole bunch of plain white boxes, and we put the patient's name on it, and we give them the opportunity to decorate it however they like, with stickers or glitter or paint or markers or things like that. And we put things in the box that symbolize reasons for living. Now, we review each item and say, tell me more about this, or why did you decide to include this item? When you think of this item, what happens to your emotions? We identify a location for keeping this survival kit, and we always want to make sure there's at least one thing in the box. Now, it could just be a reasons for living list or whatever. Well, we often will print items out because in the hospital, we don't have access to all these items, but we may print them out from the internet or things that we've typed out and bring them to the next session. So some common things are pictures from places the patient wants to go, or pictures of family, special events, pets, etc. Quotes that they find inspirational. Doesn't really matter, except we want to be very careful to vet these items to make sure that there is nothing iatrogenic in them. So, for example, methods used to commit suicide, to die by suicide, would not be appropriate. Things that are triggering would not be appropriate. A picture, for example, of that boyfriend in a highly conflicted relationship might not be a good thing to put into the box. In session 3, we do means restriction counseling and coping cards. Means restriction, the rationale is that the transition from ideation to action can be very rapid indeed. In fact, 36% of people found that they went from thinking about suicide to acting on it in less than 5 minutes. Meaning, we have to buy time and make sure that you don't have easy access to lethal means during those 5 minutes or however long it is. So we assess the patient's access to lethal means and then collaboratively develop a plan to reduce their access. Sometimes that means discarding it or removing it from the home. Sometimes that means creating barriers. Sometimes it means, creating the crisis response plan or other cues that are located with means. So we engage, we raise the issue of suicide means, ask them to share their thoughts. We focus on it by introducing the topic of safety. We evoke, we ask open-ended questions to encourage further discussion about the patient's commitment to safety. And then we plan, we assist the patient in developing a concrete plan of action for temporarily limiting access to lethal means. Now, firearms, a big deal in, I think, both of our countries, mine especially. You have to ask, at least here, every patient about their access to firearms. Now, in the case of veterans, we find that often they will not agree to remove firearms from the home, but consider alternatives. We dismantle the firearm and give the firing pin, for example, to somebody else, or store it in a tamper-proof safe that is secured by somebody else. Store it unloaded and get the ammunition somewhere else. Use a cable lock. Just completely get the ammunition out of the house, whatever it is. So we might ask the patient, what are your thoughts about firearm safety? Or maybe more to the point, what do you think about somebody having access to firearms when they're really upset and suicidal? What might be some benefits of temporarily limiting your access to firearms? And if we can't completely remove the firearms, what are some other options? The myths here, myth number one is that it won't make a difference, right? Obviously, it does. I mean, talking about this does, in fact, influence behavior. Myth number two, this conversation is going to lead to a political argument. We're not here to debate somebody's politics, and we're not here to debate their gun rights. So we consistently bring it back and frame this as a health issue, that right now you're going through something that is impacting your judgment, and we need to help keep you safe. Myth number three, which is my favorite, is if somebody really wants to kill themselves, they'll just find another way to do it. The data actually say this isn't so. The Israeli army did an interesting experiment in which they were noticing a high suicide rate among soldiers. So they created a program in which soldiers had to check their weapons in over the weekend. And the suicide rate plummeted when they had to do that. It's not like they all went out and found some other means of killing themselves. If you interrupt one means, it can interrupt the entire thing. We also identify other means. Are there other things that you've considered or used to kill yourself? Have you thought, and I keep asking it, have you thought about any other methods? And you keep doing that until they say no. So if the patient has medications in the home, we figure out a plan for how we're going to either discard them or put them in a lockbox or something like that. If it's things like knives and rope, well, when possible, we get rid of them, but sometimes you just have to get rid of their favorite knife. Or sometimes you just create barriers. Can you put them away somewhere where they're a little farther from you? Or could we place your reasons for living right next to it? If it's the car, like if the patient's going to drive off a bridge, let's talk about your route to work. How do you drive? And why could we find another way that doesn't involve going over that bridge? It is important to note that we don't insist on 100% restriction. That's just a losing battle. We want to preserve the patient's autonomy. So you don't always, for example, want to have a family member in charge of the medication. Sometimes that's just humiliating and triggering. We avoid getting into power struggles over this. We come back and emphasize our shared goals. And if the patient's going nowhere on one of our discussions, we say, well, why don't we come up with something different? We also recognize that this effort is largely symbolic. That is, a patient could kill themselves if they were determined to, but what we're trying to get them to do is demonstrate their commitment to living. We're looking to get them to slow down the behavioral sequence at least long enough for them to start to become ambivalent about dying. And we want to give them enough time to access alternative coping and hope. I'll skip that one. And then we also create these coping cards. And the coping cards is that we want to use a memory aid, a concrete cue to use your skills. So we go back to the suicide mode. And the idea is you get these index cards and you write down the element of the suicide mode on one side, and then you flip it over and you write a coping response. And we have the patient rehearse this regularly. So we have two different kinds of coping cards. One is a cognitively oriented coping card, in which side one is the suicidal or maladaptive belief, and side two is an alternative perspective. We prioritize this because if you're keeping track, you may notice we have not done anything cognitive yet in the treatment. This is really the one place that we specifically address thoughts. We also have behaviorally oriented coping cards, in which there's a specific event or situation on one side, and a list of concrete steps that the patient can take on the other side. These are some examples. You can see a couple of cognitive coping cards on the left and a couple of behavioral coping cards on the right. We then do talk a little bit about the suicidal belief system. The suicidal belief system suggests that suicidal desire to die is driven essentially by three components of the three components of pervasive hopelessness. They are unlovability, unsolvability, and unbearability. And these are the themes that we're looking for in those cognitive coping cards. These are some examples. Unlovability thoughts are I'm a failure, I'm damaged, I'm weak, I'm lost, etc. Unsolvability is I can't change it, I'm helpless, there's no future. Unbearability is I can't stand it, I can't get through it. And as we start to develop alternatives, we use common but very light cognitive therapy strategies like, well, let's talk about the evidence. Or what would you tell a friend who shared these thoughts? Or even simply, what's another way to think about that? Maybe a more helpful way. So what is something that you could tell yourself instead of people would be better off without me? What evidence do you have against that thought? And then finally, our last session of the brief CBT is a review of all skills and the relapse prevention task. And in the relapse prevention task, we do an imaginal rehearsal of using skills twice, once when thinking about the previous attempt. So we're almost giving them a mental do-over. And second, we anticipate a future suicidal crisis. So the clinician's script is for the review of all skills is I'd like to spend time today coming up with a plan for how these skills can help you to manage distress without hurting yourself after you leave the hospital. First, let's review. Then we write them on the whiteboard. We ask the patient to describe that skill and reflect on their experiences, including things like the suicide mode, the crisis response plan, the reasons for living, the hope kit, means restriction, and coping cards. And for each of those skills, we develop a plan for how the patient is going to continue using those skills after discharge. And we assess the patient's likelihood after discharge from 0 to 10. How likely are you to keep using that skill? The relapse prevention task is essentially based on the principle of covert rehearsal. So we imagine ourselves coping with a suicidal crisis. We do it twice, one previous crisis and then one that hasn't happened yet. We encourage vivid imagery, incorporating our senses, although I will say it took a while, maybe because we're fundamentally an anxiety and OCD program, it took a while for our clinicians to realize this is not imaginal exposure. We're not seeking habituation or disconfirmatory experiences. We're simply trying to get the patient to imaginally rehearse using these skills. So we identify where to start directively. orient the patient to the day of the attempt before beginning the task, and identify what skill is going to be practiced. We go back to the treatment log for that. We talk about where to insert that skill. Again, we don't want to do brinksmanship. We're not trying to get right up to the point of suicide and then start using skills. Early in the process. We practice flexibility, so we have the patient imagine it several times and imagine the scene, guide them through the procedure with prompts to get a vivid picture in their mind. So some sample prompts might be, what is happening around you? What does that sound like? Describe what it looks like. Where in your body do you feel that sensation, etc. You know, and those of us who are used to imaginal exposure are probably used to these kinds of questions. But again, this is not an exposure task, it's a rehearsal task. And then after we've done the imaginal rehearsal, we consolidate by processing the experience. How was that? What did you notice? What was easy and difficult? Why did you choose to use the specific skill that you did? What are some other ways you might have solved that problem? And always highlight changes or shifts in the patient's emotions, thoughts, or behaviors as a result of implementing those skills.
In a minute.
I'm going to skip there. So let me summarize, and then I want to open it up for some questions and discussion. Brief cognitive behavior therapy is efficacious in reducing further suicide attempts among people who have attempted suicide. And that's true at the outpatient level, which is 12 sessions. And it's true at the inpatient level, which is only 4 sessions, 4.5 hours of therapy to get a 60% reduction in suicide attempts. It is based, going back to David Rudd's essential components, it's based on a simple empirically supported model. And the major interventions that we use in BCBT-I are the narrative review and case conceptualization, the crisis response plan, the reasons for living, the survival kit or hope box, coping cards, means restriction counseling, and then finally, relapse prevention. And with that, I want to say thank you very much for inviting me and thank you for your time. And I'm happy to have your discussion.
Thank you so much, David. Very interesting presentation, and also I think very helpful and instructive to see your videos, how you actually do things here. So we have a couple of questions. I'm going to read them out loud from the Q&A, and for those who are still on, please feel free to write more questions. So first question is, thank you for this insightful webinar. Are there any data on psychiatric readmission rates in patients with comorbid borderline personality disorder or PTSD within the context of BCBT and its impact on suicidal behavior?
These are great questions. Let me answer it a couple of ways, not because I'm trying to be dodgy. The first is that we didn't have big enough numbers to do a full mediational analysis the way that we did with substance use disorders. So anything that I say is going to be a little bit tentative. What I can say, however, is that we did not see much of an association between scores on measures of borderline symptoms or the PTSD diagnosis. That is, that we didn't see any real indication that made much of a difference in terms of the efficacy of, well, in terms of the interaction of time by treatment. So obviously people with PTSD, people with borderline symptoms are always going to be at elevated risk, but we saw no reason to believe that made them less receptive to the treatment that we had to offer, if that makes sense.
Yeah, makes sense. So one related question about the group that you have treated comes from Lisa Gunnarsson, and she writes, thank you for the great presentation. And she wants to ask about an exclusion criteria, since you mentioned that this was a representative sample, but then one exclusion criteria was lifetime schizophrenia or schizoaffective disorder. And since these are disorders with a high risk of suicide, could you explain the rationale behind selecting this exclusion criteria? please?
Absolutely. Yeah. Thank you for that question. We went around and around about this for a long time because we really did want to make this sample as representative as possible. But ultimately, we were forced to exclude some patients that were thought to have impaired capacity to provide informed consent. So, for example, we also couldn't include acutely manic. We had patients with bipolar disorder, but we could not bring in a patient who was acutely manic, specifically because we were concerned that they wouldn't be able to provide informed consent. So I think that still does remain an area to be explored, is how does it work among those patients?
Okay, thank you.
But everything else, substance use and even psychosis, by the way, was allowed. I mean, we had lots of patients with psychotic symptoms, major depression with psychotic features. We had a few patients with delusional disorder. It was really just the schizophrenia and schizoaffective disorder that we had to exclude, and the acute
Okay. So one question that I had reading about your study was the rate of suicide reattempts. If I remember correctly, you had 65% reattempts in 6 months or something like that. Does that sound familiar? Or
that sounds vaguely familiar. Yeah, I should have studied.
And I in some other studies, the studied group has a much lower reattempt rate. So does that reflect something about the group that you have in your hospital? Are there many people who are like, continuously self-harming or something like that?
It may very well. I mean, I'll tell you about the Institute of Living. It is an urban hospital in a relatively poor area of the city, and that's largely the population that we serve. We also had a number of patients who were unhoused. We had so they were eligible for the treatment as well. We also noticed that we had a relatively high number of patients who were sexual and gender minority, and they did seem to be at elevated risk of suicide as well. Okay. So again, it didn't seem to matter. It didn't seem to affect the degree to which the treatment was helpful for them, but we do note that there were lots of red flags for elevated suicide risk across the population.
Okay, so questions are pouring in here. Jennifer Stanley asks, what are your thoughts on using this approach with children?
Well, I would love to see it studied. I mean, I think we just don't know. Intuitively, it's a relatively, I think that the treatment could be simplified enough that it could be applied to children. But I think we simply don't know whether it's going to be effective for children or not. I will say we did a little bit of pilot testing of an app-based version of this treatment on the adolescent inpatient unit. And it was more of a feasibility trial than an efficacy trial, but certainly it seemed feasible among the children that we studied.
Another question here is from Frida. She is interested about the ratio between wish to live and wish to die, and if that's a predictor for suicide. Is that more long-term or short-term risk? What's an acceptable ratio?
I don't think we know. That's a great question. I don't think we know what the cut scores are just yet, but we will be working on them. We are going to be coming out with an article fairly soon that talks about the predictive validity of the ratio of wish to live, wish to die. But in terms of the long-term versus short-term risk, we just measured over 6 months. So that's as much a time as we can speak to.
Thank you. Johanna Morén asks, as this treatment requires that you're hospitalized for at least 4 business days, the question is, sometimes one finds that it's better for the patient to be discharged as soon as possible to avoid institutionalization. Oh, sorry, I can't pronounce the word, but I think you know what word I'm after.
I think I get it, yeah.
What do you think about this?
We have the same issue. Some patients are discharged in 2 days or 3 days. What we would do is give them more than 1 session per day if we had to. And in fact, that happened a lot of the time. So it wasn't all 1 session per day.
Okay. Yeah, that's good to know that it can be flexible.
So you have to be on an inpatient unit because it's just things move so fast.
Oscar Flygare writes, you briefly mentioned that the question about wish to live and wish to die were associated with risk of future suicide attempts. Well, maybe this is, let's see if this is maybe overlaps with the last question. Could you elaborate on this and maybe speculate on why this is the cause?
Well, the why is always the toughest part. I think that what you're looking at is biased cognition, right? I mean, when the suicide. So I think when you look at wishes to live and wishes to die, in part, I think what that is a reflection of the degree to which the suicide mode is activated. Because the suicide mode, like all schemas, biases information processing, and it focuses the person on their reasons to die, and it gets them to ignore or forget about their reasons to live. So what we found in short is that when there are a lot more reasons to live than there are to die, the person probably doesn't attempt suicide. But on the other hand, when the balance is tipped to the other side, the risk is greatly elevated over a 6-month period. And I think that's probably because their cognition is biased. You have a biased cognitive process.
So I think this wish to live and wish to die has raised a lot of interest here. Here's another question about it. Is it really in the same dimension, or is there any advantage or disadvantage of having two scales?
It is two scales because we don't necessarily think that they are different poles on one construct.
Okay.
You could in fact have a high rate of, you could have a high wish to live and a high wish to die. Or you could be low on both. So you really have to look at them as two separate constructs.
Okay, thank you. So Fredrik Johansson has read your paper very deeply here, I can see from the question. He asked from your table 2 that treatment as usual included a lot of psychosocial intervention. For instance, 60% had CBT. Is that typical for inpatient settings in the US?
Well, I don't know if I could speak to what's typical for inpatient settings in the US, but yes, I think it's reasonable that most patients are receiving at least groups that involve some degree of therapeutic activity. Obviously, most of them are receiving medication stabilization and so on. Oh, actually, that reminds me, I want to go back to the exclusion criteria as well, because there was another really important exclusion criterion that I wish we didn't have to have, but we did, which was that if the patient was going to receive ECT, electroconvulsive therapy, we could not include them in the trial because there would be no retention of the material that we were using. So we probably lost out on a certain percent of the sample by excluding we're going to receive.
So there are some questions on what the treatment as usual was and what it did include. Did it also include crisis planning, for instance?
It did, yeah. Although we've just done some analyses showing that independent raters rated our crisis response plans as being better and more thorough than the crisis response plans that were used on the unit. So yeah, there is some of that. I mean, so it's a standard hospital, and we didn't tamper with their interventions at all, but we did try to improve on them.
Jesper Hegge asks here, interesting study. In Sweden, psychologists are rarely involved in inpatient care, where the biological medical model predominantly prevails. Do these findings suggest that this might be problematic?
Very. It's a wonderful question. I think very much. I mean, I think this suggests to us that adding a little psychology really helps. And I think most of us are aware that it's very hard to medicate away suicide, that it's just not very responsive to medication, including antidepressant medication. I mean, you can medicate the person's depression and they still engage in suicidal behaviors. So I don't think you can simply treat this as something to be medicated. They do, in fact, need some therapy.
Thank you. So a couple of questions here about the follow-up after the BCBT-I sessions, the 4 sessions. How were the follow-up sessions structured, and what did they include?
The follow-up sessions over the 6 months were solely assessment. So they were
Okay.
telephone,
So,
and it was to redo the Columbia Suicide Severity Scale.
okay, good. So, well, if I may ask a question myself here. So I think in your study, you had very strong effects, I think it's fair to say, right? You were probably a bit surprised yourself, or I don't know.
Pleasantly surprised, yeah.
So I think in the literature, it has been hard to find such strong effects. And for instance, for ASIP, which is tried at some Swedish clinics, the Swiss protocol, which has probably similar size in terms of therapeutic effort, it has failed to replicate in the only replication study in Finland, for instance. So do you think or how do you see this very strong effect? Have you really struck gold here, or what is the explanation?
Well, in some ways, I think that our study was a replication. I mean, it was an extension, at least, of David Rudd's outpatient study.
Mhm.
Essentially, what we found is that when you bring it to an inpatient unit and distill it down to its core elements, you get the exact same results. But obviously, we need a lot more replication, and I'd love to see it tried in different hospitals and in different countries as well.
Mhm. Okay, thank you.
Karlinska, if you'd like to do this, please let me know.
Yes. Let's see. So good psychiatric management, GPM, has become quite popular over here in Sweden, at least just in the recent years. And Antoinette Lundahl here writes that it reminds her of that. Probably the simplicity of it is reminding her, I'm guessing now. Are there any studies comparing GPM and BCBT?
Not that I'm aware of, but I think that's an excellent idea. I think we need to look at multiple comparison conditions, and we need some horse races to determine what's the very best thing to do.
Mm. 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 So Hakan Korkmaz asks, did the patient with substance abuse in general have higher reasons not to live than the patients with no substance abuse?
That's a good question. You know what? I don't know the answer to that. I don't know if we looked at substance use as a moderator of wish to live, wish to die. That's now I want to go back and look at that, but I'm not sure. But remember, the discrepant results with the suicidal, with the substance using patients were not on suicidal behaviors. That is, when a substance using patient received BCBT-I, their suicide rate went down at the exact same rate that it went down for patients without a substance use disorder. It's just that there was this main effect such that they were higher, so that everything was worse, pre and post treatment in substance using patients. So I don't know if that's because of wish to live, but what we saw is that the discrepant result was in hospitalization rates, which tells me, I think, if I'm thinking about this correctly, that patients with substance use disorders are still being hospitalized at a high rate, but not necessarily for suicide. So we managed to get the suicidal behavior out, but we didn't affect the overall hospitalization rate.
So given how obvious, to be honest, it seems to do something like this, I mean, we know that the rates after discharge are super high, and I mean, the patients are already in the hospital, so you don't have this problem that you lose people that are hard to contact, etc. Why do you think there is? I mean, what do you see as the obstacles for any such methods to be more widely implemented?
I'll tell you a story, and I won't name the hospital, but Gretchen Diefenbach and I gave a day-long workshop to a hospital here in the United States. And the reaction that we got bordered on revolt.
Wow. Mhm.
They were not by everybody. I think most people were very appreciative, but there were definitely a sizable minority in this audience who were angry that we were suggesting that they do anything different.
Mhm.
And they kept coming up with all kinds of reasons why this can't possibly be done, and we don't have a psychologist on the unit, and we can't afford to give individual therapy sessions to these patients, and so on. So I think, at least in my country, there is a big resistance to change, and I think there's a big resistance to allocating resources on the inpatient unit, even though I think the resource utilization is quite modest here, 4.5 hours of therapy. On an inpatient unit, that they treated that as if it was, we were asking for the moon. So I don't know. I think that there's going to be some cultural, and by cultural I don't mean like American culture, I mean hospital culture. I think there are going to be some cultural issues that we have to address hospital by hospital to get wide uptake.
Okay.
However,
Yep.
that is sort of the next direction we want to go, is dissemination and implementation. We want to sort of see how well can we train people to use this protocol, and if we do train people in a different hospital system to use this protocol, does it achieve the same effects?
Well, I hope you will well achieve this goal. It seems very important to me. And I think that was a good way of ending this seminar as well. So this is not, and thank you very much for taking the time. This has been recorded, so if someone wants to look at this later or recommend it to someone, it's possible to do that. The video will be up within a week, I hope. And this will not be our last Karolinska suicide seminar. If you are on this call, then you will automatically get an email about the next one. So thank you everyone for attending, and thank you very much, Dr. Tolin, for a wonderful presentation.
Thank you very much for inviting me, and thanks everybody for your great.
Thank you.